With me is Larry Beutler, and he is a distinguished professor, researcher, and director of clinical training in Palo Alto University. And he's also past president of the Division of Psychotherapy and Clinical Psychology of the American Psychological Association. His research has been highly influential on topics such as the psychotherapy effectiveness and the importance of adapting our therapy to the client as a whole and not just based on diagnostic criteria. I think we'll have a chance to talk a little bit more about that. He was also one of the first to specifically study the patient characteristics that impacted psychotherapy and how therapists could respond to these characteristics. So thanks for having us, Larry.
You're welcome.
Well, just to have a little bit about your own background in research, I would like to know, I know that you worked with Dr. 𝗔𝗹𝗲𝗅, a former student of Carl Rogers, and also with Saul Garfield, very influential researcher. How did these early experiences influence the work you were interested in?
Well, let me clarify a little bit. I don't think 𝗔𝗹𝗲𝗅 actually worked with Carl Rogers. The person I referred to who was before 𝗔𝗹𝗲𝗅, I was working on my master's degree, and I was working with Wayne Wright, who was a student of Carl Rogers. So my first exposure was to non-directive, person-centered psychotherapy. Now, your question is what lessons I learned at that time? Yes, indeed. I will share an experience with you that might give some insight to that. I was taking my first class, at that point it was counseling psychology, and my first class was in psychotherapy. I was assigned a client, like all of my classmates. We were assigned a client who was coming to the student counseling center. And there was only a few contingencies placed on that. The most serious was that Dr. Wright told us that once we introduced ourselves and once the client came into the room and sat down, we would conduct the rest of psychotherapy without saying anything. So we had to use gestures or non-specific, yeah, and that kind of thing. So we were to give no verbal communication with any language content. But the client came in, and of course I was scared to death, but the client came in and he sat down, he seemed quite calm, and he began to talk, and I began to pull back and away from my voice, and all of a sudden I found myself, of course, trying very hard to communicate the core ingredients of client-centered therapy: acceptance, non-specific acceptance, and empathy and warmth and congruence and all of those nice things. And at the end of the session, he stood up, and at that point I was going to schedule another appointment with him, and I was to ask him a little bit about how he liked the session. And we'd gone through the whole session, and he hadn't noticed I was quiet. He said it was the best session he had had, which was not very many by that point, but he was really appreciative of the treatment or the intervention. And it made me aware that there is a significance here to doing less. Sometimes doing more is doing less. And that's a lesson I think I've retained a lot and try to pass on to my students. The corollary of that is there's great power in nothing. If you do nothing, there's tremendous power.
And in your work, you've also said sometimes that first the relationship, so these core values that you bring into the research and from client-centered therapy, they're present from very early on.
That's true. That's true. I've always placed great stock in the relationship as a foundation for it. Yes.
Yeah. So it's now focusing on your research. Well, it's interesting. This connects very well. You know, you shook the field at the beginning by criticizing the one-sided paradigm, where we basically try to match a specific treatment model to the diagnosis, leaving out a lot of patient variables. So before telling us the need for this broader treatment matching that you do and research, can you tell us your thoughts on how far diagnostic-based research has taken us and how it failed us?
Yeah, well, I think it has done both. I think the thing that it has done the best is that it has really emphasized the importance of research in psychotherapy, of being able to to utilize research principles to guide psychotherapy. And so practitioners who have adopted this perspective place great reliance on research findings. Now, the unfortunate part of that is that they place great credence on only randomized clinical trials.
Yeah.
And that is not all of science. It is not all of psychological science, and it is certainly not the model that governs a lot of other physical sciences. I mean, we can't do randomized trials on gravity, for example. We can't make randomized trials on a lot of things that we can only study naturalistically. But what happened at that time, and I remember almost the moment at which it happened. It was an SPR meeting. I was the president-elect of SPR at that time, and we were meeting anyway, it was in Connecticut somewhere. I can't recall exactly when, but we had at that meeting the head of NIH at that point, NIMH, I should say, and he was expressing to us in a keynote address that psychotherapy should be like aspirin, that you should know the ingredients, they should be the same every time you give it, and we should study it in the same format. So we adopted at that time, with the first randomized clinical trial, the old treatment of depression study, we adopted that perspective, that psychotherapy was like aspirin. We need to know what the ingredients were. We needed to be able to deliver it. And at that very moment, we switched our attention from looking at the therapist and the patient to looking at the intervention. And psychotherapy became equivalent to the intervention. Yeah. So in the early studies, and even to a very large degree in the current studies, therapist factors, non-diagnostic patient factors are randomized out. Yeah. They are considered to be noise variables, error variants. I learned in my work that with that early exposure to client-centered therapy, that you couldn't consider the relationship a noise variable. You had to consider it within the context. Psychotherapy is more than intervention. It is a coalition of variables that the therapist and the client together have control over. Yeah. And since they have some control over them, those things can be psychotherapy, whether it's assignment to certain kinds of people, therapists, etc., or whether it's adapting, the therapist adapting to the client, or even the client adapting to the therapist. But it has to include at least the participant characteristics, patient and therapist, contextual characteristics that include the environment and the social support systems that the patient has, and the relationship and the interventions. Yeah. It has to include all of those variables to really represent what is psychotherapy.
Yeah, so in a way you were able to move away with your research, move away from this tendency to almost a medical model applied to psychotherapy.
Yeah, right. It was a medical model. I mean, we were running away from the medical model by adopting the medical model. Yeah. We ran away from it in our clinical practice and adopted it in research. And I think that has retarded the progress of the field. Yeah. And it has retarded the progress because it has held out a big sign that says there are some treatments that are better than other treatments, and it's ours. Mine. Yeah. And so everybody has come to believe. I in my classes, I challenge my students a little bit to tell me what psychotherapy is the most effective. Mm-hmm. And almost uniformly, they come up with cognitive therapy. Mm-hmm. Interestingly, if I give faculty members that same question, they come up with the same answer. Yeah. They believe that cognitive therapy is the most effective therapy. In fact, I heard a guy at the American Psychological Association meetings not long ago say that if a clinician did not practice cognitive therapy in this day and age, they were engaging in malpractice. Ooh. Now, that's a very extreme perspective, given the fact that research across the board tells us that, one, that the intervention isn't all of psychotherapy, yeah. And two, it counts for only a little bit of the variance, some 10 to 15% of outcome is attributable to the interventions one used. And most of the time, when you compare interventions, you get the dodo bird verdict.
Exactly.
You get that the observation that all get about equal effects. I can show you meta-analyses in which interpersonal psychotherapy is more effective than cognitive therapy. I can show you analyses in which psychoanalytic therapy is more effective than cognitive therapy.
Yeah.
But those are in the minority. Most of them show that they're about the same.
Yeah, it's interesting. I can imagine in the 90s, but even before, when these meta-analyses came out and the big dodo bird verdict that everyone won, I can imagine you were one of the people laughing, like, of course.
Yeah, well, but I sold my soul too. I engaged in a lot of those randomized clinical trials. Now, we've adapted them a little bit.
Yeah.
And I felt the necessity of doing that because as my own perspective evolved, I became more and more convinced that if you look at the intervention and put it within the context, you're going to get better effects. And so we always did randomized clinical trials of different types of psychotherapy within the context of looking at principles that govern the interaction and contributed to the interaction, drawn from therapist, patient, intervention, and relationship care.
Yeah, let's get into that. So a major focus of your career has been the research of treatment matching, or selecting the most appropriate treatment for each patient. And you've developed a procedure called systematic treatment selection to help clinicians to do exactly that, to treatment match. So can you walk us a little bit through this process of how you created this systematic treatment selection and how it evolved?
Sure. Well, as I said, my early experience was with client-centered therapy, but that was when I was working on my master's degree. When I started to work on my doctoral degree, I got a whole big wider range of interventions.
Yeah, sorry, let me just ask you this. Would you consider yourself a psychotherapist of any orientation nowadays?
No. No. I'm an inclusive therapist, an integrative therapist, and that's the way I would define myself.
Okay.
Specifically, but you can see, if you look at my history, how the many different components got kind of incorporated. But initially it was that the theory was important. The theory guided me. Client-centered theory guided me. And I was thrilled when I first got to meet Carl Rogers in 1971. Oh. And years later, I got to work with him a little bit as he was giving some presentations. I was asked to kind of help him find his way around and spend time at the table with him and so forth. And it was a great challenge and a great interest to me. But by that point, I was also convinced that client-centered therapy was no more the whole answer than any other thing. Yeah. I had developed the concept of integration way back when I was looking at my doctoral degree. My dissertation was on trying to predict psychotherapy outcome using different persuasion models from social psychology. So we looked at dissonance theory. Could we explain outcomes with dissonance theory? Could we explain outcomes by social judgment theory? Mm-hmm. They give different kinds of predictions about what the relationship between the therapist and the patient will produce. Mm-hmm. So the therapist was considered to be an advocate. His or her own personal values and values about the world, perspectives of the world, served as a template that the patient was to adopt. We considered, in other words, that the therapist was a persuader. He wasn't just a passive listener. He or she was a persuader. They systematically set out to say, I want you to become more like me, and that will be healthy. And in fact, the literature suggested that over the course of time, there was a convergence between the two. It was the patient that moved, and it wasn't moving towards a general view of psychotherapists. It was moving towards this therapist's view of religion, of sex, of all of these subjects, including things like the dependency, the role of dependency, the role of interdependency, etc. And we began to look at those things as predictors of change. And it worked.
Yeah.
But there was a flaw. The flaw was, well, the biggest flaw was that therapists didn't like that kind of research because they didn't want their value systems to be studied. They considered it so fervently to be A, theoretical and A, judgmental. And in fact, they were quite judgmental. I was working at that point at Duke, and the therapists were almost all psychoanalytic therapists. And so I got a nice exposure to that and also some exposure to individuals who were open in all aspects of their life except in that therapy room. They didn't want anyone else to know what they were doing.
Yeah.
And so I was forced almost to move out of that view into a broader view, and the view I adopted was, okay, if I can't match the therapist to the patient, let me match the intervention to the patient. And so in 1982, I published it was actually my second book, but the first one on psychotherapy, and it was called Systematic Eclectic Psychotherapy. So I was kind of following on the heels of Arnie Lazarus.
Yeah.
To develop an eclectic psychotherapy, but mine was based upon certain characteristics that were offered by the therapist. They were not considered to be inherent to the therapist, although some of them turned out to be kind of inherent to the therapist. They fit with the characteristics of the patient, and that was the start of where I am now. But the difference is that at that point, what I wanted to do is create a menu of techniques that we could fit with any given patient. So it was the techniques, the level of techniques we would fit, and we would change the world. Well, it turned out that techniques are not a very good place to start because psychotherapists all use techniques. Some of them maybe use the same technique, but they use it so differently you'd never recognize it.
Yeah.
They had different skills with different techniques. So we really had to match it more consistently as evolved over time with looking not at technique but at principles or strategies, if you will. And from that I was borrowing from 𝗔𝗹𝗲𝗅, the concept of matching at the level of strategies. I generally rejected his as well because of it. I considered it, and I didn't reject it. In fact, we still work with stages of change, stages of readiness as part of the principles. But it was a movement to be more inclusive than he had been in that. And besides, the research hadn't shown too much about how you could fit those variables of treatment and stage of change together and really make a differential effect. Turned out that the higher the readiness, the better the outcome, regardless of what kinds of interventions you use.
Yeah.
So we incorporated that. But that moved us, and it was 1990 when I did the first book on, and I was still thinking within an eclectic perspective, look at techniques. But I worked with John Clarkin on that book, and just doing it got us both to the point that we were looking not at techniques but at strategies. Somewhere between theories and techniques, there is a concept of strategies. What is the strategic role of the intervention?
Does this have any relationship with the strategy level of Marvin Goldfried?
Well, it does. Marv was a contributor to that point of view, and in fact articulated it most specifically in his 1981 book. Yeah. And we adopted that that concept, and I think it was Prochaska articulated that, Marv Goldfried articulated it, and Leslie Greenberg articulated it, and we gathered from all of them and said, okay, well, this makes good sense. If we can't do it at the level of technique, let's do it at the level of strategy, and that has held. So as I started out as a client-centered therapist, I became a technical eclectic, and then an integrationist, and that piece of it has held. So that's where I am. Yeah.
Okay. So based on your work and this research, what can you tell us in 2016 to be the most important patient characteristics we should look out for?
Well, we were just finishing a book right now Mike Constantino, 𝗔𝗹𝗲𝗅, and myself. I'm actually the third author on it, although it started out as my idea. It usually derived from the book that 𝗔𝗹𝗲𝗅 and I did and published in 2006. Mm-hmm. And what we did is we took the 13 or 18 principles that John Clarkin and I, or excuse me, Bruce Bonger and John Clarkin and I had articulated in 2000. We started with those principles and began a dialogue and it was very active on at the Section 3 of Division 12 Internet groups. People were trying to look at what are the foundation and fundamental principles of psychotherapy that would account for the fact that psychotherapy so often produces the same effects regardless of how you get there. And so I had taken that fairly seriously, and the three of us had put together 18 principles out of looking at broad bands of literature, thousands of studies, and trying to articulate the finding and condense them into a few small principles that match patient characteristics with treatment characteristics. Mm-hmm. And we have been fairly successful in doing that. But now we had the chance. I was at that time president of the Division of Clinical Psychology for APA. And 𝗔𝗹𝗲𝗅 was the president of the North American Society for Psychotherapy Research. So we collaborated. And we got people together to review the literature from different points of view. We matched them. We paired them to make sure there were contrasts there. We had them identify from that body of literature, and we gave them the Handbook of Psychotherapy and Behavior Change. We gave them some textbooks on interventions, and we said, review all of these studies within your domain, and we gave them several domains, a domain of depression or anxiety or personality disorder or chemical abuse. So we divided those four. And we looked at participant factors, we looked at relationship factors, and we looked at treatment factors. So we had a whole group of authors, 2 authors on each chapter, doing that, and then they pulled in other authors to help them. And we extracted from that now 64 principles. It was really an interesting process because we got all of these people together, people representing each of those chapters. And we sat down, and they each came with a list of what they thought the principle was. And we put them together in groups in different ways to extract from that the principles that were common to all of these 4 domains and those that were specific to a particular domain, like depression or chemical abuse. Mm-hmm. Turned out most of them were common. But out of that, we did not adequately make sure that the principles were equally well established in research. They were established in the research, but they weren't equally established. So what we've been doing in the more recent book is going back to those 64 principles, condensing them, and looking again at what is the evidence for them. Yeah. And we will be publishing this. We still don't know how many principles it's going to be, but it'll be somewhere in the high 30s. Wow. That we can identify these are the principles. Okay. They underline everything that we do as psychotherapists. Mm-hmm. If we can take this broader view of psychotherapy, this is the meat that cuts across theoretical perspectives. And what's important is instead of building from theory down, we're building from data up. Yeah. So all of them are grounded in outcomes. The criteria of including any variable is, does it produce an effect? Is it a mediator or is it a moderator of change? Yeah. Now, in the course of doing this, our research has gone on. So what I have done, and I won't blame any of this on my colleagues there, except they helped us articulate the principles. We pulled out 8 principles. My research group pulled out 8 principles that we currently work on and say that these are the ones that seem to be the strongest of those 37, 38, whatever they're going to be. These are the ones that are strongest. They have the most research behind them. Mm-hmm. And we put those together. And I'd be happy to share with you essentially what those patient characteristics are. Yes. And what the corresponding characteristics are. Please do. For example, the first principle that we work on is the relationship of functional impairment to outcome, and look at it as both a mediating and a moderating variable. So, for example, there is a correlation, fairly strong correlation, between the level of impairment and the the slowness of outcome. So it's an inverse correlation. More impaired the person is, the less benefit they get. But that can be moderated. And the moderator is social support. Mm-hmm. So if you can activate social support, you can offset some of the effects of functional impairment.
Very interesting.
And the therapist's job then becomes, let's get the social support going. It also is a function of relationship. Relationship moderates it. So we've introduced a couple of principles. We have 3 in our list of 8 that are relationship-oriented: how to initiate the relationship, how to maintain the relationship, and how to relate to it when there are ruptures in the relationship. All of that drawn from the literature. And then we look at such things as the resistance level of the patient, which has turned out to be a very strong matching dimension. The directiveness of the therapist inversely with the resistance level of the patient. So whatever they do, if you can get the therapist to be responsive to the resistance level of the patient, the better off you are. Unfortunately, therapists tend to look at patients and judge the resistance to be there, so they don't do anything about it except attack it. Unfortunately, perhaps unfortunately for others, we take the position that resistance is a characteristic of the interplay, the relationship. And so the activation of resistance on the part of the patient is a signal to the therapist that you're not being appropriately sensitive to their needs for control and power and dominance. Mm-hmm. So we teach them how to respond to that. Then the other variable, patient variable, is coping style. Mm-hmm. And that too has turned out to be very robust. And if a person is heavily, and you can look at stability of coping style, you can look at one being elevated over the other. There are 4 kinds of patterns that can exist, obviously, both internalizing and externalizing, which are the coping styles, and not 2 ends of the same dimension. They're separate dimensions. Internalizing and externalizing are both high. One's higher than the other, internal or external, or they're both low. And those mean different things in terms of treatment. So matching with the focus on insight, which is received very well by internalizing patients, or the focus upon changing behavior, which is received fairly well, but with some struggle, but managed pretty well by externalizing patients. Mm-hmm. And then, of course, we move out of that domain. We can look at the preferences of the therapist and the patient about the therapy, and the stage of readiness. Yeah. That the patient has, which really gives us a cue for how well they're going to develop a relationship and what we can do at the end of therapy to facilitate their continuing growth. I'm being long-winded.
No, this all sounds fantastic to me. I would like to ask you, do you have any idea when this book will be out, this last book?
Well, we're working on the final chapters as we speak, so Great. It should be out by the end of this year. It'll be coming up by Oxford University Press. Mm-hmm. It will be the 2nd volume to our book that I did with Kasten Gay, Principles of Therapeutic Change that Work. We've taken that, and that's the foundation for what we're doing now, which includes, incidentally, I'm really excited about this book because the test of everything is after we've put the principles together, we've identified what they are, we've identified how strong their research anchor is. Now we give those principles to people who spend their life doing psychotherapy. Yeah. You know, practitioners who spend most of their time in psychotherapy, and we give those principles to them with a little bit of explanation about them. And we also give them a vignette that describes a particular patient. Yeah. And ask them then, okay, take these principles and tell us how you would use these principles. What ones you would use, what ones you wouldn't use, how you would use them to deal with this patient. Mm-hmm. And now we're just in the process of doing that, so I have no results. But that's an exciting, to me, prospect.
Of course. Well, I'd like to grab what you're saying and segue into psychotherapy training, because we want to use this research that you're talking about. So I've read in the past that you don't really appreciate the way psychotherapy is conventionally taught. We've already talked a little bit about this. It's very maybe model-based. It comes from a top-down level, so I can instinctively understand your reservations towards it. But I'd also like to know your thoughts on principles to train effective therapists. I read that you tried a little experiment because for many years you taught first the theoretical models and then later these core principles of psychotherapy. And in more recent years, you did it the other way around. You tried to teach the core principles and then the theoretical model. At the time I read about this, you weren't particularly satisfied with the experiment. Can you tell us what happened?
I'm still not satisfied with that part of it, but we have had some wonderful success.
Okay.
Because now what we do is say, well, it really isn't whether you teach one or the other first. It's how you teach it. Yeah. And that gets us back to the model. So my biggest concern with traditional academia and teaching psychotherapy is that it operates according to what Paul Guest and I at one point called the germ theory of education. The idea that if you expose a person to it, they'll catch it. So you teach them the theory, and you then make them, by virtue of they adopt a theory, now they're cognitive therapists or whatever, okay? So the approach that we've moved through is, and I'll give you a little background to this. We tried to do a randomized controlled trial some time ago in which we had three types of therapy. We had a narrative therapy that we developed for the project. It was really focused upon allowing people to develop and change a narrative that they had through the use of all kinds of ancillary materials, books, movies, etc., to which they could identify, with which they could identify. And then we had a cognitive therapy group. The sample was cocaine abusers with depression. And then the third one was a systematic treatment selection model, prescriptive therapy, we called it at that point. And the prescriptive therapy did as well as any of the other treatments. It did as well as cognitive therapy, which was better than narrative therapy. So it essentially tied with cognitive therapy. Well, that's a good thing, but it's a disappointment. We wanted it to come out much better. So I took a long look at what we did. And what we did is we did the germ theory of education, unintentionally. We gave them a workshop on prescriptive therapy, STS. We gave them the workshop. We showed them videotapes. And then we sent them into the field to do it. Yeah. And they loved it. Yeah. But they didn't do it. They loved the idea of it. They could articulate it, but they didn't do it. When we looked at what they actually did, they did what they've always done. Now, in recent years, we've been looking at a more intensive way of training them. So for our training now, it's not divided by training in theory versus training in integration first or last. We now train it first in the clinic, even though they've gotten their theoretical training before. Now, most training clinics use supervisors to come from a wide range of backgrounds. They come from such a wide range that most of their approaches to psychotherapy are not even represented in the theories course that we give. They're kind of making their own theory. Now, so, because it seems like most psychotherapists in one way or another kind of blend different approaches. And they also have their own personalities involved. So what we've done now is say the point at which we need to teach them integration is when they're seeing their first client. So we're focusing upon supervision. And the thing that we're doing is training the supervisors in how to teach integrative psychotherapy, systematic treatment selection. We train them how to teach it. And one way that we use is that we have to observe the student, and the student has to be coached in how to use it. So we get the videotapes and we monitor what they do systematically. We have a form that does this called the Therapist Process Rating Scale. And it can be completed in a very short period of time by either observers or by the client or by the therapist. We like to have two people do it, the therapist and the client, or the client and a outside rater. The therapist is least likely to really know what they're doing. So when we look at what we can get the therapist to do, we really get some powerful effects compared to supervision done in its usual way. And that's a study that you wanted to talk about it a little bit more. I can give you more details. It's under review right now. That one has not been published, although a precursor to it, a prelude to it, was published in Psychotherapy about a year ago. That described our approach to supervision there. And it's just extended that pilot data that we had to a more sizable sample.
And by the way, you've talked about patient characteristics, and I'd like to, also talk about the therapist characteristics. We know from the research that therapist effects are quite big in comparison, at least with the models. So what are your thoughts and the research on this topic specifically? Are there any set of characteristics you feel that is essential or more important?
Sure, they should be like me.
And tell us how you are.
Well, the most important therapist characteristic is really flexibility. The therapist to do a strategy-based intervention where they don't have a theory to guide it. They have principles to guide it. They have to be quite flexible. Now, if they are too rigid in their theoretical approach, they're not going to be able to do this very well, even though we can use those principles within almost any theoretical structure. And most of our research has looked at adding the principles to the effects that one gets with their own preferred therapy, cognitive therapy most often, narrative therapy, sometimes psychoanalytic therapy. We've studied those kinds of interventions. And if you add the principles to those, the outcomes are enhanced by an effect size of about 0.6. Now, that's increased over whatever happens by the Dodo-Bird verdict. So it's a good, strong effect size. But it's important that the therapist stay flexible in order to do that. It's also important that they get training from a wide variety of interventions. So they need the broad theories course, and they need to have enough familiarity with it that it serves as a guide for them. Because there is a critical point at which theory is important in our model. It's not usually important. We don't look too heavily upon causal theory. We're looking at empirical theory. If you put these variables together in this way, you get positive outcomes. We don't always know why, but it helps if you're working with an internalizing patient, where insight is the goal. Then we need to have a theoretical model. The therapist has to have a theoretical model that helps them identify what insight is, what insight they have to have into what. So I use, for example, a dynamic variation of Hans Strupp's, where we look at people's repetitive patterns, and we identify them in terms of, I call them acts, like acts in a play, and they're 4 basic acts in my way of formulating. They have a need system, then they try to get that need met, and then they have a particular response from the environment, positive and usually negative, and they conclude something about themselves and the world. I'm no good and the world ain't much better. So when the problem occurs, because that fourth act of the play is also the first act of the next round. I have a need that's not met, and here we go again. So it helps me with the internalizing patient to identify what this recurring pattern is and how it might be broken. Now, we do it then with internalizers. We encourage the therapist to utilize a formulation that extends beyond STS, but that's almost the only instance in which that occurs. In all other respects, we like to keep it at the strategic level, close to the data. But essentially, you see where I'm going with this, that we have to be optimally flexible as therapists. And the less flexible we are, the less effects we can hope to achieve.
I can imagine you would agree then with this term of the need for responsiveness that your colleague John Norcross talks about.
It's exactly. John incorporates within that a number of different variables. I think you can separate flexibility generally out of that, and it is a characteristic that we really try to emphasize. Yes, John actually has been involved in our development of the assessment tool that we use, and in a lot of the writings that we're utilizing.
Well, tell me something. For someone who's seriously interested in applying systematic treatment selection, or as you called it before, prescriptive therapy, in their own practice, for example, in Portugal, how are we going to do that? Can you tell us?
Yeah. Well, I have some ideas. I'm not sure they're not proven ideas completely yet, but one, any advice I would give starts with this. Start measuring outcomes.
Okay.
Start measuring change. Do it objectively. Don't do it subjectively. Get a symptom checklist or get a rating scale of their quality of life, something to evaluate outcomes, whatever outcomes you think are valuable. As it turns out, multi-symptom characteristics are pretty predictive of almost all outcomes. If you get change in symptoms, you're getting change in a lot of other outcomes. So we tend to utilize our particular instrument, which utilizes 22 different symptom areas, and that's the InnerLife.com. And you can look at it online. Yeah.
Okay, and you recommend this every session?
No, we don't do it every session. Because not with our instrument. Our instrument is a little trait heavy. We look at more chronic symptoms, so it changes slowly and it changes relatively small. You can do it every session with a measure like the 𝗔𝗹𝗲𝗅 of Michael Lambert's, or there's a variety of others around. The old one, the SEL90, is still valuable. Those are good ones, and they're more reactive.
Okay.
So you can get a better indicator of change very early. So we often use both. We use the 𝗔𝗹𝗲𝗅 and we use ours because they tap into different kinds of things.
So, okay.
Quite symptom specific.
So first monitor the outcomes. Okay.
Exactly.
What next?
First of all, monitor the change.
Okay.
And then after that, it becomes a matter of becoming educated and checking your education. So become familiar with the principles, and the ones particularly that you will use. Interesting, the principles are additive. So you don't have to use all of them. Somebody in Germany, and I don't even know these people, but they did a randomized clinical trial on psychiatric inpatients getting either systematic treatment selection or psychoanalysis.
Okay.
And they found that with one of their groups, one of the major treatment groups, the predictors they had for the STS, what they made the STS into, was nicely predictive of differential change. They're going to get better with this or this treatment. So you could make a differential selection. The problem with that particular study was they just picked principles out of the air. They didn't take any of the ones that I've mentioned, except preferences. They did include preferences, but that's about it. And so it looks like, you can kind of select some of the principles, but I'd encourage people to learn and study these 8 principles that we're looking at now. I think they're still the strongest. We need to look at preferences, and the STS InnerLife.com incorporates all of those and some others in trying to get a narrative report that will tell the clinician the directions that would be optimal for them to go. So there is that. You can learn it. Then you can evaluate your patient. Third step is evaluate your patient on some, and you don't need to use the InnerLife.com, but it's the simplest one, and they're all together. But get measures of the characteristics that you think are important in your use of those principles. Make sure that they're reliable measures. And then start doing therapy. But record it, so that you can, with a colleague, with somebody, with a student, with a client even, go through a measure of what you're doing. And our recommendation is the TPRS, and we will supply that to people on request. And it's a rating scale where the clinician, in one form, rates the session, and it's done session at a time. They rate the session in terms of both what they did and their intentions. Some questions are about intentions, some questions are about what they actually did. And the the other person, an observer or the client, can do the same thing. And then you take the mean ratings of those for each of these characteristics. Gets 5 factors, one of which is skill level. The others pertain to, are they oriented towards insight, or are they oriented towards behavior change, or are they oriented towards directiveness or non-directiveness, etc. So you'd look at each one of these characteristics, and you look at your patient, measuring it now on a series of scales or on the STS, and you say this patient has high functional impairment, this patient is a high externalizer, this patient has high levels of resistance, etc. And at that point, then, you can identify which of these interventions and what kind of magnitude, relative magnitude, can be offered to this patient for optimal change. Now, we're in the process of doing 2 things that kind of cap all of this off. One, we're going to program a separate program on the website so that you do that rating and then you plug in your scores and the computer will generate what the optimal treatment is and what the level of compliance is. And that, I think, would be advantageous as feedback to the therapist, not just the patient's outcome. Feedback the outcome, but also feedback your compliance with the treatment principles. And then that gets to the thing of how to really change your behavior. And then finally, we're just going to be marketing now very, very quickly. The DVDs are done. We have a series of 5-hour to hour-and-a-half DVDs that go through how you train a supervisor. Now, in our research study, the outcomes are always the patient level. So we train the supervisor, then the supervisor trains the therapist, and we measure the outcome of the patient. And we find that the more systematically the supervisor trains,
the better the outcomes of
the outcomes are better, substantially better.
Yeah.
So those are kind of the steps we're headed for. We want to make an integrated program to teach therapy.
When you talk about recording the sessions, I suppose the ideal would be video recording.
If you can, yes. Because you get a lot of information from nonverbals. 60-70% of the information you get is from nonverbal communication. So that's very helpful.
Okay.
I used to keep a little camera right by my side. Something I learned during my Gestalt training. Keep a little camera right by your side. And then you can stop and give them feedback. But you can also keep the tape then and do ratings on it.
Great. Oh, by the way, this is just catching on. We're on our last minutes here, but I would like to ask you, because you've talked about monitoring the outcomes, and there's been quite some research in recent years about this. And one of the phenomena that happened was finding out that there seemed to exist something called the super shrinks. So some therapists seem to have hugely better outcomes than the rest of us. So what is your take on that? There's still very little research on that. So
there's not a great deal of research on it. On one hand, you think of these as outliers. There's also on the other end of the spectrum people who are superly poor. They're poor therapists. Now, the interesting thing about them, and we've done some little projects on this, and I know other people have looked at people at these ends of the continuum, at the very super shrinks and the pseudo shrinks. And we looked at it a number of years ago with just one class of psychiatric residents who we followed for some time in their early careers. And we measured them during their training in terms of how well they produced outcomes. So we were really looking at patient outcomes. And then we had supervisors rate them and rank them. How well do you think they do? So supervisors and actual outcomes allowed us to arrange them in a continuum from the worst, who regularly got their patients worse off, more than half of their patients got worse, to super shrinks who actually got almost all of their patients doing well.
Yeah.
And then we asked the therapists to rank themselves. And this harkens to this whole self-judgment thing that is of great interest right now. I ask my students, for example, I want you to rate yourself in terms of your colleagues. What percentile are you?
Yeah.
Well, of course, 85% of the class is above average. It's consistent. 85% are above average. Well, that was true here too. People who were the poorest therapists and knew it very early got out of psychotherapy as a profession.
Okay.
We had a small sample. We only had 2 or 3 of those who were really in that end. But all of them, they got into administration.
Yeah.
Or they went into a different business. The people at the high end who were good and knew it, they continued to be good psychotherapists.
Yeah.
But there were also some at the top who were good and didn't know it.
Okay.
And they got out too, and that's to the detriment of the...
So
I think we do have to consider super shrinks. My own belief about them is that one, they are flexible, so we have those characteristics, but they also are good at matching. Mm-hmm. They pick the patients that they can do good work with. Mm-hmm. Now, in studies of this, of course, you usually get them randomized, so you kind of get that factor out of it, but you still have the fact that they can intuitively adapt to the patient. They follow the principles, even though they don't know the principles.
Yeah.
They follow them intuitively. See, it's that group we don't need to train much. But they do what we have identified as effective in enhancing outcome. That's my suspicion.
Okay. Larry, just one final question. It's been great. We've covered a lot of information here. I'd like to ask you, just to finish off, what's the advice you wish you would have received when you were starting out as a psychotherapist?
That's a good question. That's a good question. You sent me that question, and I haven't come to a good answer. Partly because I got a lot of very good advice. I didn't follow it often. So your question really maybe should be, what advice do you wish you had followed?
Yeah. Sure, why not?
And I think it would come back to the one I actually started with. Don't lose sight of the relationship. Don't lose sight of the relationship. I think people get enamored with techniques. And even using our approach, we know that if you take just the worried well, you don't need these principles. All you need is the first 4 principles. 1 on functional impairment. These people will be low functional impairment, and that means relationship. Work on relationship. And then you have 3 principles of what the relationship should be: how to start it, how to keep it going, and how to deal with it if you have ruptures. And for 70% of people, that is sufficient.
Yeah.
And I think that, although some certainly, I know that my colleagues would disagree with that because they're so involved with the theory and the technique and the technology of making it specific. But for 70% of people that come to you, you're not going to need that level of specificity. It's the other 30% that really needs this kind of specificity.
Mm-hmm. I think that's a great way to finish off. Thank you so much, Larry.
Thank you. It's been nice to spend some time with you.